Dear ladies and gentlemen, I have planned to give this talk in person on Sunday. However, there were circumstances that did not make this possible, so I'm happy to give this talk on a virtual base, and I hope to see you next year in the next ESNCH meeting. So I talk about assessment of collateral flow, and I want to talk about complementary value of ultrasound and magnetic resonance angiography. So I have three illustrative cases. The one case with multiple intracranial stenosis. I will compare ultrasound with static MR angiography. I have patient with a common carotid artery occlusion with interesting introduction of the dynamic magnetic resonance angiography, so-called 4D MRA, and the last example is anterior posterior subclavian steal syndrome, and I show you how MR angiography can help in assessment of difficult cases. First patient was a female with recurrent brain infarction bilateral with no arteriosclerotic risk factors, with subacute right side stroke and acute left side stroke, which led to admission. And we see a bilateral stenosis, MC bilateral. Left side was symptomatic, and also anterior circulation was affected. In the posterior circulation, there was a stenotic area in the left PCA, and I show you how we did assess this with ultrasound. So the left MCA stenosis was pronounced with aliasing effect, so you can easily identify the location and place your sample. Very high flow with 300 meters per second. With reduced flow post-stenotic as expected. We also find the stenotic flow in posterior cerebral artery. On the other side, right posterior cerebral artery, we have elevated flow on the entire vessel, not limited to a circumscribed area. So this is a hyperperfusion effect and not an effect of a circumscribed stenosis. (200 centimeter per second). MR angiography showed a rete mirabile, which we interpreted it as a hint for a Moya-Moya syndrome. The patient was also presented for extra intracranial bypass. There was a date with a neurosurgeon from Berlin Charité, but the patient did not go to this date, and so she took dual platelet inhibition. Fortunately, 6 months later, she was clinically stable despite a lack of operation, and the MCA stenosis was still present with steps in the snow. And the PCA stenosis with musical murmur, seagull-like sound. It's interesting because it's very rare in PCA, common in MCA, as we all know. I hope you did hear the sound. So we proceed to the next case. And this patient presented with an internal carotid artery lack of ICA flow with a CCA occlusion of the common carotid artery. It's difficult in the assessment of the bifurcation to identify the vessels. We have one vessel with an autograde flow, and this is a retrograde flow with a pattern which could be a pattern in a patient with an intracranial blood supply. However, the direction is away from the brain. There's the flux. So retrograde flow, perhaps in the internal carotid. Orthograde flow in the other vessel, probably the external carotid artery with a venous sound also, because it's a very small vessel and the venous signal cannot be discriminated completely. Intracranially, we have a low flow in the middle cerebral artery on the left side, which corresponds also to a reduced signal in the time of flight angiography. ACA does not contribute to the flow with autograde ACA. So what happens? We have a very strong posterior communicating artery. And we have a strong flow in the P1 segment. This is also visible on the MR. And just to remind you, a strong communicating posterior artery. So what happens to show this? We rely on MRI. There's special sequences with very fast imaging. Very fast imaging means we must make lower resolution or lower contrast K space, the technical term in the processing of MRI signals. Can be scanned in the center, so we have a low resolution, or we scan the periphery, so we have a low contrast with high resolution. However, in case of gadolinium enhanced angiography, we have a intrinsic high contrast, so we can live with low contrast due to the portion of the K-space scanning. The sequence is very fast, 20 frames per second, and they are combined to a maximum intensity projection. So as you've seen in the next slide, there is a digital subtractive angiography feeling when you look at the pictures. These are the acronyms, differ from the manufacturers, but most of them are in the package with the cardiac imaging. So these are sequences developed for cardiac imaging, but available also for extracranial vessels. So we have a static MR angiography. We have one vessel here. It may be the internal carotid. We have one vessel there. It's the external carotid. I suppose there is a reverse flow in the internal carotid. We have the 4D MR angiography. 4D is for the time. So we have a contrast agent in the brachial vein. We have a contrast agent in the aortic arch. We have a contrast in the right common carotid and the right internal carotid, also in the left vertebral. And what happens here? We have the ACA ipsilateral on the right side, and we have a low flow in the MCA on the left side. Comes from the basilar artery, from the posterior communicating artery as a collateral. But what happens next? There's another vessel. This is the internal carotid. It flows retrograde to the bifurcation and makes a U-turn and the blood supply goes into the external carotid artery in autograd direction with a reverse flow from basilar artery, communicating artery posterior down the internal carotid with U-turn with complete lack of common carotid artery. This is case number 3, presented with a high-grade internal carotid artery stenosis on the right side and the corresponding border zone infarctions. This is not very uncommon and not so interesting. So what is interesting in this case was that the patient had a very prominent left communicating posterior artery. We also found a retrograde flow in the P1 segment on the left side with a pattern with a high systolic flow. P2 segment then is autograd with a lower flow. And the communicating posterior artery has also a high flow with about 180 centimeter per second. Transnuchal display of the vessels. Here the magnum foramen shows the retrograde basilar artery. And a retrograde flow in left vertebral artery with lack of diastolic signal that is corresponding to the blood supply to the subclavian artery on the left side. In the static MR angiography, we see the subclavian stenosis, not very prominent, and we see a strong left vertebral artery and how it is supplied in the intracranial circle of Willis. Therefore, we have to rely on the 4D MR angiography, so the 3D, which we can turn in the space. It shows the vessel but not the flow direction and also gives no good information of the circle of Willis. So when we check the 4D MR angiography, we see a left internal carotid autograd and a flow reversal in the basilar artery and in the vertebral artery. I show you soon. So we have the right brachial vein, we have the aortic arch filling, we have the left internal carotid. The right internal carotid comes slowly because there is the stenosis. So we have the left internal carotid, and we see also the filling of the vertebral artery retrograde. The vertebral artery is filled completely now and goes to the left subclavian artery in case of anterior-posterior steal syndrome. So in conclusion, dynamic MR angiography and color-coded duplex are complementary. Small vessels are difficult to assess in color-coded duplex, so MR angiography and CTA may help. Identification of vessels may be difficult in color-coded duplex in case of flow reversal. So you cannot rely on the identification due to the flow. So the dynamic contrast MR angiography can help to assess pathological collateral patterns. So thank you very much for your attention, and I hope you found this talk useful, and I wish you a good conference and a safe trip home.